I hope I can provide some relevant data about gender differences in renal damage, because there are many studies about very difficult molecules, but that then they are difficult to measure, and then we need to prove the importance of this molecule. But women are half of the population. Just to forget that, not to forget that. We already know that we are facing a pandemic, but there has been a long-standing pandemic in worldwide, and there is no need to explain that obesity is a major pandemic. And obesity is associated to many things: hypertension, prediabetes, cardiovascular disease, metabolic syndrome, cancer, psychological complication, and a long list of etc. And as we are nephrologists, we need to think about any possible relationship between obesity and CKD, or chronic kidney disease. This is a picture you know very well. This is a SU study from the Kaiser Permanente database showing that the higher the BMI, the higher the risk for CKD. But I think there is a large gap between epidemiological studies, particularly in big studies of hundreds of thousands of people, and real life. Because obesity and CKD do not show a parallel increase. So if obesity is really a risk factor for CKD, we expect a higher number of CKD patients worldwide. Why? I just think about two possibilities. CKD is a slow progressing disease, so we may still need time for those obese people to develop CKD. But we have been under this pandemic for 30 years. On the other line is that perhaps not all obese are at risk for CKD, and this is what I think. Is there a specific subgroup of obese patients at risk for CKD? Let's explore. Of course, I think that the patients with metabolic syndrome are the specific subgroup. Metabolic syndrome, you know very well, is a coincidence in the same patients of many metabolic changes: dyslipidemia, prediabetes, obesity, overweight, hypertension, inflammation, possibly with a common background of insulin resistance. Gerald Reven, which was the father of this syndrome, said that insulin resistance is the common soil that link all these factors. But you may have been noticed that all these factors are risk factors for CKD. According to that, this is a beautiful study I always talk about. It's a Curela study from the ARI group. They follow up a long number of patients for 9 years of follow-up, 12, I don't remember well. And they said that the higher number of metabolic syndrome traits, as expected, the higher the levels of insulin resistance, and the higher the risk for CKD. So metabolic syndrome is an established risk factor for CKD. And this is the study of Hashimoto saying that patients with metabolic syndrome and obesity, the so-called metabolically unhealthy obesity, is the specific subgroup of people at risk for CKD. So, according again to Reven, all obese individuals are not created equal. Those with insulin resistance are at risk for cardiovascular disease, diabetes, etc., etc. Possibly, also these people are at risk for CKD. And we need to explore that a bit more. I haven't talked about menopause yet, but the question is, can we go further? Can we select a more specific group of patients at risk? And I think it is postmenopausal women. Why? There is a clear association. There are some studies saying that the risk for CKD increases, or the incidence of CKD increases after menopause. This is a study from Korea showing that the shorter reproductive lifespan duration, the higher the risk. If you have a short reproductive lifespan duration, you have early menopause. And early menopause is associated with the incidence of metabolic syndrome. And then they didn't analyze metabolic syndrome, but they found, trust me, that the green line is those with a shorter lifespan reproductive period. So this early menopause was associated with a higher incidence of CKD. And what about bilateral oophorectomy due to many causes? This is also associated with an early appearance of CKD. But coming back to metabolic syndrome and linking that to menopause, you must know that there is a dramatic increase in metabolic syndrome after menopause. The global prevalence of obesity is higher in women than in men in all continents. Visceral obesity plus metabolic syndrome is 2 to 10 times higher in women. And this exacerbates terribly after menopause. Just to pick to define an issue that I like very much, which is prediabetes. Women have lower levels of fasting plasma glucose, but have higher levels of IGT. And this increases also after menopause. Impaired glucose tolerance is more prevalent in women. Accordingly, women with metabolic syndrome have a high risk for cardiovascular disease. And this is something that has been well known. So menopause leads to obesity and metabolic syndrome, and these may go into a high risk for cardiovascular disease. What about CKD? I think this is the best evidence from clinical studies, again from Korea, showing that the increase of CKD after menopause is linked to an increase of metabolic syndrome after menopause. In the left panel, you can see the incidence of CKD in women and men. It is higher at this age. On the right, you can see the incidence of metabolic syndrome between women and men. That is higher after the same age. And here you can see the incidence of CKD in men and women. And women in the red line show a higher incidence of metabolic syndrome after the age of menopause. And these may be linked to a specific phenotype in diabetic nephropathy in women. We found some years ago, we did a review in the Diabetes Working Group and found that a non-negligible number of patients with diabetes may progress into renal disease without proteinuria. And this phenotype of CKD without proteinuria in diabetes, sorry if I'm jumping into diabetes, but metabolic syndrome and diabetes are common things. This non-proteinuric GFR decline was observed in women. It's the first time in nephrology that I can recall that gender is a risk factor for something. So I finish with the epidemiological studies that are quite few, but I think they are consistent. Let's go to animal studies, and we have done some studies in our group with Anna Elena, which is somewhere there, because the evidence in the clinics is limited, but the pathogenesis only you can study that in animal studies. Let's go with obesity and renal damage in mice models and large animal models. And I think it's something we need to consider, not to stop with mice, just to try to find studies or to do studies in large animals, which are quite similar than human beings. This is an elegant study from Dominguez showing that it's a model of hypertensive rat with metabolic syndrome. I think they were fed with cafeteria food or McDonald's food, as you can call it. They use male and female animals. This is highly unusual. In many studies, we have been working always with male mice to avoid the interference of the hormones, estrogen and progesterones, every month, every 20 days. So there is a tremendous lack of information about animal models using female animals. They use male and female animals, and they observe that only male have fibrosis in the tubula and the glomeruli. Non-castrated female rats were protected from obesity-related damage. you can see this is obese male and this is obese female. But these females were not castrated. This is a very elegant study in sheep in which they induced obesity by the restriction of the movement of the animal, and they observed glomerulomegaly in obese male, but obese female didn't have any histological sign of renal damage despite the similar level of obesity. But these sheep were not castrated. Let's go to models in perimenopausal or menopause. We did 2 studies, and I would like to show you the studies in aged swine. This is a study we did in Madrid with Antonio González de Bulnes, which is an expert in the field of large animal studies in metabolic syndrome. We selected a group of perimenopausal definite age animals that are having problems with having piglets. Female Iberian swine. The Iberian swine is the famous Spanish ham, and this is a model of insulin resistance. We randomized these aged female animals to standard or cafeteria food for 3 months. Of course, obese animals develop metabolic syndrome, and we measured GFR and did histological analysis in the animal after sacrifice. You can see that glomerulomegaly was observed in obese female, increased mesangial expansion was observed in obese female, and we did iohexol. For this study, we developed the method for iohexol in swine, and obese animals hyperfiltrate. So it is not just menopause, because the other group had menopause but without obesity. We need the interaction of menopause and obesity to induce renal damage. And interestingly, and this is an underexplored topic, we found diabetoid changes in obesity and metabolic syndrome animals without diabetes. These animals didn't develop diabetes. I forgot to tell you that we did oral glucose tolerance test to test prediabetes and diabetes. You can see increased mesangial expansion and some, I don't know if I think this is some nodular lesions resembling early damage according to the diabetic nephropathy classification. And please see these pictures. These are kidneys from the swine, indistinguishable from human kidneys. If you go to the pathologist, he or she won't be able to say this is an animal or this is a human. This is why we like to work with large animal models. And then we developed this study with Anna in mice. We took a large group of mice, male and female. We induced obesity with cafeteria food, and we castrated some of the female animals. We did intraperitoneal glucose tolerance test to evaluate diabetes at regular time, and we did also the plasma kidney of iohexol that was developed for this study in mice. As you can expect, obese animals on cafeteria food develop obesity, but castrated and non-castrated females develop the same degree of obesity. So obesity was comparable between both groups of female animals. But despite a similar increase in weight, female animals showed a worse glucose, worse result in the glucose tolerance test. So they didn't develop diabetes, let's say just pre-diabetes. This is the insulin tolerance test. They also develop insulin resistance despite a comparable level of obesity. And they showed insulin resistance despite a comparable level of insulin. This red is obese castrated and gray is obese non-castrated. So obesity-induced metabolic syndrome and insulin resistance only in obese castrated females. So there is a lack of protection against the damage of metabolic syndrome due to menopause. What about renal damage? As expected, obese males develop hyperfiltration, and in the female group, hyperfiltration was observed only in the obese, castrated females. So the hormones, sexual hormones, were protecting from hyperfiltration, which is an early marker of renal damage. Interestingly, albuminuria in females was only observed in obese castrated. Obese non-castrated did not show albuminuria, despite a similar increase in weight. And finally, glomerulomegaly was only observed in obese females castrated. Not even obese males showed glomerulomegaly. Only was observed in obese non-castrated females. So early markers of renal damage were only observed in obese females castrated. There are some things in nephrology that are underexplored, and one is the number of glomeruli we have. I don't want to go into this detail, but there are some studies saying that women have a lower number of glomeruli than men, and we found that in rats. Female animals show a lower number of glomeruli compared to male animals. So, despite a comparable increase in weight, obese castrated females show early renal damage, glomerulomegaly, albuminuria, and this is compared to males and non-castrated obese males. Possibly, as a side product, a constitutional lower number of glomeruli may also play a role in obesity, menopause, and renal disease. Please don't ask about the pathogenesis of that, because it's terribly complicated and we know nothing. The only things I could pick up for you is that insulin receptors for insulin resistance are highly expressed in the tubuli, and there is a theory saying that tubular cells do not develop insulin resistance. If you develop insulin resistance, you may be protected from the actions of insulin. But if in the context of high insulin levels, the tubular cells are not protected, you may have damage. And there is a lot of upregulation of intrarenal renin-angiotensin receptors promoted by insulin and hyperinsulinemia. And this may contribute to sodium reabsorption, where we know very well the tubuloglomerular feedback, hyperfiltration. But estrogen receptors it happens that are highly present in the kidney, and they block every action in the kidney that insulin can have. And this is striking. Estrogen reduce insulin sodium reabsorption. Insulin block the renin-angiotensin-aldosterone system stimulated by insulin. So I won't go into the detail of that figure after lunch, but if you remember all the pathogenic points related to hyperfiltration, sodium reabsorption, renin-angiotensin system, the tubuloglomerular feedback, vascular regulation, etc., all of them are blocked by estrogens. All of them, at least in animal studies. So, to conclude, there is an increased risk for metabolic syndrome and insulin resistance after menopause. This may be associated with the risk for CKD in this population. And postmenopausal women is a risk group very seldom evaluated. And they are half of the population. I cannot conclude without remarking the tremendous help I receive every day from this fantastic group. Thank you very much.
Thank you very much, Esteban, for your provocative talk. And many questions in the audience? Yeah.
Thank you for a very interesting talk. Have you stained for or examined if there are ectopic fat accumulation within the kidney?
Yes.
Also, which kind of fat?
We are currently, the two photographs in the swine, they were stained for adipofilling. This is a very difficult aspect because some obese animals were full of lipid droplets, and some obese animals who are not, there was no droplet at all. And in these animals, we are now doing a full lipidomic analysis of the kidney. We are analyzing the type of lipids, free fatty acids, and the free fatty acids in the subgroup of lipids, the fingoline, etc., etc. So we are doing that. And we hope we can also find some lipid markers in the urine of these animals.
And just one more question. Have you tried to also use kidney transplant kidneys and examining them? Also try to correlate BMI with ectopic lipids?
In menopausal women?
Yes, when they get when they get their transplant, if they're postmenopausal and obese, and see if you can replicate the findings you have seen in the animal models?
No, we haven't. We're just focusing on regular CKD, but this is a point. I acknowledge it is a point.
Thank you.
I have, thanks very much for this kind presentation. I have a question from Trond Jensen from the chat. Thanks, Esteban. You see signs of renal damage in castrated animals that also tend to have glucose intolerance. Is the kidney injury related to castration per se or glucose tolerance? As you may know, glucose-intolerant humans hyperfiltrate according to iohexol measurements, which is shown in the Tromsø study.
Yes, thank you. I love the Tromsø studies, and thank you, Trond, for this question. This is brilliant. We don't know. I think there are so many things that induce hyperfiltration, and one of them can be weight, insulin-resistant, glucose intolerance. And also the other way of the coin is that male animals have the same degree of obesity or more, the same degree of glucose intolerance or more, and they were not castrated. I mean that there is possibly a link of many things. The induction of hyperfiltration due to glucose intolerance and the possible lack of protection due to the lack of estrogens. A combination of both things, I think. But it's just supposition right now.
So my additional question is there a time effect? So is it like that during the course of the lifetime, do you see then a shift in the effect of this intolerance?
In the model?
In the model, yes.
Well, the model lasted 6 months, I forgot to say, and now we are currently doing a model of 12 months. So we want to see if the male develop more damage, and the damage is more severe after 1 year after menopause. So I think this is something we need to see, as well as to wait until we find more chronic lesions, like fibrosis and atrophy that we didn't find yet. Maybe as in all animal models, you need time.
Okay,
If your hypothesis is it is the lack of estrogen that induces these damages, have you tried supplementing with estrogen in the same model and see if the effects are abolished or mitigated?
Will be done in the next step.
Cool.
Of course, because the evidence in humans is quite limited, just some studies. But I think that if we do that in humans in study, must be women after menopause with flourish metabolic syndrome, albuminuria, some kind of renal impairment, not everyone. But the next step will be to supplement with estrogens. And see, there are some studies in animals, but they are controversial.
Okay, some questions. Esteban, one short question is, what are your experience with the early postmenopause? Is the same effects like in all other models?
One model was in aged swine. animals of 10, 12 years of age. But still, they were aged animals and they had perimenopausal. The non-obese animals were perfect. The kidneys were perfect. It may be plausible that we need more time. You need at least 6 months with estrogen deprivation or hormone deprivation to get more damage. I think, yes. This is the problem, as we've been told yesterday from the researcher from Gubra. You need models that provide chronic lesions, and for that you need time, and the mice last 2 years if you're lucky.
Okay. I was wondering, in a clinic, I mistake always the gender and diabetic patients. Which option as treatment in the future do you think it is possible to use in menopausic diabetic female? Is it possible to use hormones or other?
The point is that it's completely unexplored. We don't know how many studies have done evaluating gender differences in GLP-1, SGLT2, ACE inhibitors. Possibly quite few. And how many studies have been done saying, okay, if it is true that estrogens are protecting against the damage of insulin resistance in the kidney, how many studies have been done to test these effects and with strong renal outcome? Quite few. It's a problem. There is something in the epidemiology and there is something in animal models, and in between there is a vacuum too large, and we need to start filling it, I think.
Okay. Any comments or any questions? Thank you very much for your presentation and for your answers.